Good morning, everyone. My name is Dr. Aditya Kunte. I'm a fellow in GI and expertise surgical oncology at Data Hospital. Today, I will be discussing study protocol for a phase 3 multicenter randomized control trial of adjuvant Folfox HAIC versus observation in surgically dissected cases of hepatocellular carcinoma. Now we know that after curative resection for HCC, the recurrence rates range from 50 to 80%, with most of the recurrences being intrahepatic and majority of them occurring in the first 2 years. Until now, there is no definitive evidence-based adjuvant therapy approved for the treatment of HCC. Even the large STORM trial for adjuvant sorafenib showed no benefit, and consequently, the major guidelines also do not recommend any adjuvant therapy. Hepatic artery infusion chemotherapy has been emerging as a treatment modality for hepatocellular carcinoma and has proven its mettle in advanced unresectable setting, and as well as with the improvement in OS and DFS. There have been studies with agents such as 5-FU1 cisplatin and 5-FU-interferon in the adjuvant setting for HAIC, which have also demonstrated DFS benefit. And more recently, we have evidence that Folfox HAIC in the adjuvant setting, the preliminary results from this ongoing clinical trial show that there is a possible benefit to this treatment, which can reduce recurrence rates and prolong survival in the curative setting for HCC. So the aim of my study is to assess the efficacy of adjuvant Folfox hepatic artery infusion chemotherapy in surgically resected HCCs. The primary objective being to assess the impact on disease-free survival by addition of adjuvant Folfox HAIC compared to observation only in surgically resected HCCs. Now, secondary objectives will also be to assess the impact on overall survival, the intrahepatic recurrence-free rate, and the treatment-related adverse effects of Folfox HAIC. So my study hypothesis is that adjuvant Folfox HAIC improves the DFS of surgically resected HCCs compared to observation alone. The methodology is that this is a phase 3 randomized controlled trial, a multi-center design. The study population is the surgically resected hepatocellular carcinomas, and the experimental arm will be consisting of adjuvant Folfox HAIC, and the control arm will only be observation, which as of now is the standard of care. The study population will include patients of newly diagnosed HCC in whom a curative R0 resection has been performed, and who have a performance status of ECOG 2 or less, and with adequate organ and with no organ dysfunction at screening. HCCs with mixed histologies will be excluded at the time of screening if there is presence of portal vein thrombosis or presence of extrahepatic disease or residual intrahepatic disease. Those patients will also be excluded, and patients with who have received more than 3 sessions of preoperative TACE will also be excluded from the study. Patients will be screened 4 to 6 weeks after resection of the HCC, after which eligible patients will undergo a stratified block randomization with respect to the status of microvascular invasion, and then be randomized in a 1:1 ratio into the 2 arms of the study, which is the 2 cycles of Folfox HAIC versus the observation arm. The primary endpoint of the study is 3-year DFS rate, and the secondary endpoints are 3-year intrahepatic recurrence-free rate, 3-year overall survival rate, and rate of grade 3 and 4 adverse events with HAIC. So the treatment procedure involves 2 components. One is the actual hepatic artery cannulation, which will be done under local anesthesia. The access to the hepatic artery will be gained via the femoral artery. The GDA will be routinely coiled, and the catheter tip will be positioned at the junction of the GDA and the common hepatic artery. And the proximal end of the catheter will be connected to a routine infusion pump. Patients will also be kept on routine anticoagulation. Subcutaneous low molecular heparin will be used for anticoagulation. And the chemotherapy regimen consists of the Folfox regimen, consisting of oxaliplatin and fluorouracil from day 1, followed by a 46-hour infusion of 5-fluorouracil. The second cycle will be omitted if, due to complications arising from the first cycle, the second cycle is delayed by more than 4 weeks from the scheduled date. The patients will be followed after completion of treatment. Patients will be followed up for a total of 3 years. The recruitment period for the study is 2 years, making the total duration of the study of 5 years. And the patients will be followed up every 3 months for the first 2 years and every 6 months for the last third year. At every visit, patients will undergo a routine physical exam, a serum ALT, routine biochemical investigations, and also contrast and CT scan of the thorax, abdomen, and pelvis every 6 months. So we have estimated the required sample size for a DFS benefit of 8 months with HAIC as compared to observation with an alpha of with a two-sided alpha of 0.05 and power of 8% and an estimated dropout rate of 10%. The minimum required sample size would be 274 with 137 patients randomized to each arm. And the survival analysis for the study will be performed by Kaplan-Meier tests, and the difference in survival will be tested by a log time test. A p-value of 0.05 or less will be considered to be statistically significant. Now, in order to assess the impact of the study, it is also very essential to understand what the disease burden of this particular entity is in our country, and the age-adjusted incidence rates of HCC in our country are between 3 to 5 per 100,000 population, which translates into a volume of nearly 30 to 50,000 new cases of hepatocellular carcinoma annually. And based on the reported figures, it is estimated that there is a 5-fold difference between the reported and actual incidence rates. And
so 1 minute left.
We also have an estimated 25 to 30,000 new cases of HPV annually, and HPV being the most common etiology for HCCs in India, this forms a very big public health burden in our setting. So we stand to develop a treatment to set a new standard of care in the adjuvant setting, where at present there are no approved therapies in existence and therefore provide much better outcomes to these patients undergoing curative surgery. Thank you.